Welcome to the debate. So, if you hand two people the exact same topographical map, right, and one is walking in, say, heavy boots, while the other is driving a highly advanced all-terrain vehicle, they are going to experience that landscape in completely different ways.
Oh, absolutely. I mean, the map itself hasn't changed. The mountains, the rivers, the sheer drops, they're all identical.
Right, exactly. But the boundaries of what they can navigate and, well, how safely they can do it have shifted entirely.
That is a brilliant way to frame it. The terrain is a fixed reality, but the vehicle you choose fundamentally alters your interaction with that reality.
Yeah, and when we step into the operating room, particularly in the complex, really unforgiving landscape of the human abdomen and pelvis, we face this exact tension. So today, we are looking at the ultimate map.
The human body.
The human body. Specifically, we're debating a core question drawn from Dr.Atef Ahmed's highly regarded text, Colorectal Surgery Code.
Which is just a fantastic resource, by the way.
Oh, it really is. And actually, just a quick note for our listeners before we dive in. If you want to follow along or just upgrade your library, you can get a massive 80% off this book and all medical books at books.dratef.net right now. Just use the code AR665398 at checkout.
Wow, 80%. That's incredible.
Yeah, it's a huge deal. It's also available on Amazon, Lulu, Patreon, pretty much everywhere. But let's get into the debate. In modern surgery, what matters more to achieving the best possible outcome for a patient? Is success dictated by an uncompromising adherence to the anatomical map, those embryologic planes that have existed since we were in the womb?
Or does the vehicle, like the advanced robotics and laparoscopic platforms we now use, fundamentally redefine what is actually surgically achievable?
Exactly. I will be arguing that the map is everything. Deep anatomical knowledge forms the uncompromisable code of surgery. The vehicle you drive through it is, well, strictly secondary.
And I will be taking the opposing view. I certainly won't argue that the map isn't essential. I mean, we're surgeons. But a map is purely theoretical if you physically cannot navigate the terrain it describes.
Right.
I will argue that advanced minimally invasive technologies are not merely secondary tools. They are transformative elements that actively redefine a surgeon's ability to navigate complex anatomy. They push the boundaries of precision in ways that, frankly, anatomical knowledge alone simply cannot guarantee.
Okay, let's lay out our foundations here. From my perspective, anatomical mastery is the absolute, non-negotiable baseline of colorectal surgery. Dr. Ahmed's text states it beautifully. He says, embryology dictates surgery.
Yeah, that's a powerful line.
It is. He makes the point that most technical errors in this field aren't really tool errors. At their core, they are anatomical errors. If you look at the colorectal decision pyramid outlined in the book, it is incredibly telling.
Right. The pyramid that structures clinical judgment.
Exactly. So at the very base of this pyramid, you have patient physiology. Moving up to Tier 2, you have anatomy, which dictates safe dissection. Tier 3 is oncology, getting the cancer out, where radicality is just non-negotiable. It isn't until the absolute apex of the pyramid, Tier 4, that we encounter modality. The choice between opening a patient up, using a laparoscope, or docking a multi-million-dollar robot is placed at the very top because, well, it is merely a tactical choice.
A tactical choice, but a critical one.
Sure, but it is built entirely upon that Tier 2 foundation of anatomical respect. Whether you hold a traditional steel scalpel, a straight-stick laparoscopic brass spur, or a robotic joystick, the physical landmarks don't move. The origin of the inferior mesenteric artery is right where it has always been.
That's true.
If you do not understand the map, the most advanced vehicle in the world will only help you arrive at a catastrophic complication much, much faster.
Well, I see the logic of the pyramid, obviously, but I come at it from a different way. Setting modality at the top doesn't mean it's the least important. It means it's the pinnacle of the execution.
Okay, explain that.
The text places a specific, undeniable emphasis on what it calls robotic pelvic precision. It details how the robotic platform provides distinct advantages like magnified 3D vision, tremor filtration, and fully articulated wrists.
But those are just enhancements, right?
They aren't just luxury features for the surgeon's comfort, though. They offer unprecedented advantages in highly challenging environments, specifically what the text refers to as narrow pelvises.
But anatomy is anatomy, regardless of how narrow the space is.
In theory, yes. But theoretical knowledge of an avascular plane is practically useless if the surgeon's instruments cannot properly reach it, visualize it, or navigate it without causing collateral damage to the surrounding structures.
I don't know if I'd say useless.
I mean, in a practical sense. Therefore, I argue that the modality acts as an equal active partner to anatomy. It is the technology that actually enables the precise dissection required to prevent those catastrophic complications you mentioned.
Okay, let's test that idea by taking our listeners directly into one of the most critical and perilous procedures in this entire field, the total mesorectal excision, or TME.
Oh yeah, the benchmark.
For those listening who might not be familiar, this is the gold standard surgery for rectal cancer. The goal is to remove the rectum and its surrounding fatty tissue, the mesorectum, as one perfect intact package. Dr. Ahmed's text explicitly refers to the dissection plane we use to do this as the holy plane.
It's a beautifully descriptive term for a very specific anatomical layer.
Right. Think of it like the very thin, white, stringy layer between the peel of an orange and the fruit itself. If you stay exactly in that layer, you can remove the orange without spilling a single drop of juice.
Which is the goal.
Exactly. If you drift into the fruit, you leave cancer behind. If you drift outward into the peel, you cause catastrophic damage. And that brings us to the pelvic danger zones outlined in the text. Danger zone 1 is the presacral venous plexus.
The basivertebral veins.
Yes. And hold on, just so I'm picturing this right for everyone listening and making sure I'm conveying the severity of this. These are valveless veins located deep to the presacral fascia, right against the bone of the sacrum.
Right.
Because they don't have valves, if a surgeon accidentally breaches that fascia and nicks them, there's nothing stopping the blood from just pouring backward out of the bone, right? It just flows and flows. That sounds like an absolute nightmare in the operating room.
Oh, it is one of the most feared complications in pelvic surgery. Massive, life-threatening hemorrhage that is notoriously difficult to control because, well, the veins literally retract into the sacral bone.
Wow.
Yeah, you can't just clamp them or tie them off like a normal blood vessel.
Exactly. And what prevents that breach? It is sharp dissection, profound spatial awareness, and perfect traction and countertraction by the surgeon. The tool does not matter if the surgeon's anatomical spatial orientation drifts even a millimeter posteriorly into that fascia.
Okay, but
The avoidance of the presacral veins is dictated by the surgeon's disciplined mind and their understanding of the map, not by the machine they are using.
that is a compelling argument for spatial awareness, I'll give you that. But have you considered the physical realities of the human pelvis? Yes, the holy plane is the target, but executing strict adherence to that areolar tissue is incredibly difficult when you are working in a space the size of a cereal bowl.
It is tight, certainly.
And we aren't just talking about the presacral veins behind the rectum. We have to consider the lateral pelvic sidewall and the anterior dissection plane. You have the pelvic splanchnic nerves, the nervi erectans.
The nerves responsible for sexual function and bladder control.
Exactly. They sit right there in danger zone 2. And anteriorly, in front of the rectum, you have de non-Valerius fascia, which separates the rectum from the prostate or the vagina.
Right.
Wandering anteriorly risks profound urethral injury. Now, the text points out that robotic platforms are specifically beneficial here. Why? Let's go back to the vehicle metaphor. Let's talk about the rigid fulcrum effect of traditional street stick laparoscopy.
Explain what you mean by that for the audience.
So imagine trying to perform complex origami using long chopsticks pushed through a tiny keyhole in a door.
Okay, that sounds nearly impossible.
It is, because of the pivot point at the keyhole, the patient's abdominal wall. If you move your hand on the outside to the left, the tip of the instrument on the inside goes to the right. If you move your hand up, the tip goes down. That is the rigid fulcrum effect. It cannot bend.
Right, I say.
In a narrow, irradiated male pelvis, where the tissue is already stiff and scarred, traditional tools fail. The robot's articulated wrists essentially put a human wrist inside the patient, completely eliminating that fulcrum effect.
So it physically mimics the hand.
Exactly. It physically allows the surgeon to maintain the integrity of that holy plane at angles that the human hand, using traditional tools simply cannot achieve. The technology doesn't just assist, it is the mechanism that preserves urogenital function.
That's a great analogy, the origami through a keyhole. It certainly highlights the mechanical advantage, but I would frame it differently, because you are focusing heavily on elective, highly controlled environments.
Well, most surgeries are elective.
True, but let's look at the limits of this technology. Relying entirely on advanced robotics for safety is like relying on a highly advanced GPS. It might guide you perfectly in ideal conditions, on a paved highway, but if the bridge is out, a storm is raging, and you're in a hostile environment, you still need to know how to navigate off-road, by instinct alone.
Okay, I see where you're going with this.
The text dedicates an entire section to emergency open colorectal surgery.
True, the acute emergency scenarios.
Right. We are talking about unstable patients, hostile abdomens, closed-loop obstructions, ischemia, or fecal peritonitis, meaning, a hole in the colon is leaked into the abdominal cavity.
A truly critical situation.
In these situations, open laparotomy, a traditional large incision, remains the absolute gold standard. When a patient is crashing, the principle Dr. Ahmed outlines is damage control and rapid source control. You might perform something like a Hartmann's procedure.
Right.
And for the listeners not in the OR, a Hartmann's is basically when you remove the diseased, ruptured bowel, sew up the rectal stump, and bring the healthy colon out to the skin as a stoma, right? You're prioritizing getting out of the operating room with a living patient over putting the plumbing perfectly back together.
Yes, that is the classic damage control approach.
So in those moments, the robot is not just unhelpful. Taking the time to dock it to the patient is a dangerous waste of time. The core code of surgery kicks in. Prioritize physiology, understand the anatomy quickly, and save the life. Technology takes a backseat to raw surgical judgment and anatomical instinct.
I absolutely acknowledge that open surgery is necessary for extreme emergencies. And the text clearly outlines those damage control principles for hemodynamically unstable patients. But I'm sorry, I just don't buy that we can define the primary operative logic of an entire medical specialty by its extreme exceptions.
You don't think emergencies define the baseline of a surgeon's skill?
I think they define their emergency management skills, certainly, but the vast majority of modern colorectal practice is elective. It's planned. And in those cases, the modality is absolutely central to the outcome.
How so?
Let's look at the text's breakdown of laparoscopic advantages and geometry. The text explicitly states that minimally invasive surgery offers meaningful benefit. It specifically cites reduced surgical site infections, or SSI, and reduced postoperative eyeless, which is when the bowels temporarily fall asleep and stop working after the trauma of surgery.
Which keeps patients in the hospital longer?
Exactly. We use triangulated ports to create an atraumatic environment. The text emphasizes a specific anatomical approach enabled by these tools, medial to lateral dissection. You start by scoring the peritoneum over the promontory to isolate the main blood vessels early, before you even touch the colon itself.
Right. Going for the root first. Right. Forcing an open midline incision when minimally invasive options are viable causes immense, unnecessary physical trauma to the abdominal wall. Modality selection here is directly tied to the patient's recovery in what we call ERS, Enhanced Recovery After Surgery pathways.
The recovery protocols.
Yeah. The day 0 to day 3 recovery timelines are fundamentally accelerated because we minimize the physical trauma of the approach, even while completing the exact same internal anatomical resection.
You bring up patient recovery, which is vital, but what happens when prioritizing a minimally invasive approach compromises the actual goal of the surgery, getting all the cancer?
Well, it shouldn't compromise it.
But the text is uncompromising about oncologic radicality. According to Dr. Ahmed, radicality is non-negotiable for malignancy. Let's talk about complete mesocolic excision, or CME.
The standard for colon cancer. Right. For a left-sided colon tumor, the embryologic origins dictate that you must perform a high apical ligation of the inferior mesenteric artery, the IMA, right at its origin, at the aorta. Let me break down exactly why this is so critical.
Go ahead.
Cancer spreads through the lymph nodes like a highway system. By going straight to the root of the IMA and cutting it at the aorta, you aren't just removing the tumor, you are taking out the entire highway before the cancer can take an off-ramp.
You are harvesting the entire lymphatic basin.
Precisely. The oncologic rule in the text is that you need a minimum harvest of 12 lymph nodes for accurate staging of the disease.
Failure to retrieve adequate nodes risks understaging the patient, meaning they might not get the chemotherapy they desperately need.
Right.
Furthermore, when you ligate or tie off the IMA so high up, you are cutting off the main blood supply to the left side of the colon. You must rely entirely on collateral perfusion to keep the remaining bowel alive for the anastomosis, the reconnection.
The marginal artery of Drummond.
Exactly. So, for our listeners, if we cut the main power line, the IMA, the marginal artery of Drummond is basically the emergency backup generator for blood flow. It's a collateral vessel that runs along the inner border of the colon.
And it's crucial.
The text states you have to confirm adequate flow via this artery and the arc of Riolan before you transect. If you haven't checked that the backup generator is working before you cut the main power, the bowel you're trying to reconnect will literally die from lack of blood.
Yeah, an anastomatic leak.
Which is devastating. This entire sequence, the lymphatic mapping, the vascular ligations, checking the collateral perfusion, is pure, unadulterated anatomical logic. It is physiologic math. The cancer doesn't care if a robot, a laparoscope, or a scalpel divided the vessel. It only cares that the entire embryologic envelope was removed en bloc.
You are absolutely right that the cancer doesn't care about the tool. But the patient certainly does, especially when we talk about what happens after the cancer is gone.
Okay.
You mentioned radicality, but the text explicitly requires us to weigh that radicality against functional preservation. Yes, you must secure a minimum 5-centimeter proximal and distal bowel margin for colon cancer and a negative circumferential resection margin, meaning at least 1 millimeter of healthy tissue around a rectal tumor.
The 1 millimeter rule is vital to prevent local recurrence.
It is, but the text also warns heavily against the consequences of being too radical without precision. It talks about severe low anterior resection syndrome, or LARS, and profound urogenital dysfunction.
Because of nerve damage.
Right. Let's go back to that high IMA ligation you just mentioned. Danger zone 3 is right there. The superior hypogastric plexus, which is a dense network of sympathetic nerves, rests right on the sacral promontory, immediately beneath where you are tying off that artery.
And if you damage those?
If you damage those sympathetic nerves during that high tie, you can permanently destroy the patient's internal sphincter tone and their ejaculatory function.
Wow.
So if you're listening to this and wondering why a single millimeter of tissue matters so much, it's because a millimeter to the left might leave cancer behind, but a millimeter to the right might leave a 45-year-old patient incontinent or impotent for the rest of their life.
The stakes are incredibly high.
Exactly. Minimally invasive modalities, through enhanced magnified 3D visualization, are precisely what allow modern surgeons to thread that needle. They allow us to achieve the radical negative margins for oncologic cure without sacrificing the microscopic nerves that guarantee the patient's long-term quality of life. The tool elevates our ability to execute the anatomical theory.
I concede that visualization is enhanced by these platforms. I mean, being able to see a nerve magnified 10 times is obviously an advantage.
A huge one.
But even with that advantage, the text notes that most errors are still anatomical. Blind clamping and a bloody field guarantees ureter or nerve injury, regardless of whether that clamp is held by a robotic arm or a human hand.
Well, true. You can't be reckless.
Right. The golden rule stated in the book is, anatomy dictates the operation. You mentioned threading the needle. You must explicitly protect the retroperitoneal ureters, particularly the left ureter which perilously crosses the iliac bifurcation. And you must visually confirm ureteral paracelsus, the actual muscular twitching of the tube that carries urine before transection.
Absolutely. Identifying the ureter is paramount.
But my point is that the visual maps in the book, the peritoneal reflections, the fascial envelopes, these exist independently of the approach. When a surgeon is operating, the constant internal dialogue the book encourages, why this plane, why this vessel, why this anastomosis, is rooted in the map, not the vehicle. The true code of colorectal surgery is an unyielding respect for embryologic planes and mature clinical judgment. That is what dictates safety across all platforms.
And I will summarize my position by returning to the reality of the operating room. Yes, anatomy provides the perfect map. But as surgeons, we are fundamentally interventionists. We require the means to navigate that map safely.
Okay.
Whether it is overcoming the rigid fulcrum effect of straight stick laparoscopy or leveraging the tremor filtration of robotic platforms in a tight, narrow pelvis, modern modalities are what actually allow us to execute the complete mesocolic excision and total mesorectal excision to their fullest potential.
They certainly aid in it.
They transform patient outcomes by reducing surgical trauma, minimizing ileus, and granting us the exact precision required to save those delicate autonomic nerves. Anatomy is a destination, but technology provides the essential means to arrive there safely.
Well, I think where we strongly converge today is on the underlying philosophy of the surgeon as outlined by Dr. Ahmed. The text states beautifully that the approach is a method, a modality, not a mandate.
I love that quote.
Right? The best operation isn't just the most technologically advanced one that can be performed. It is the one perfectly tailored to the patient's specific physiology and pathology. In a crashing emergency, that might be an open Hartmann's procedure. Electively, for a low rectal tumor, it might be a robotic ultra-low anterior resection with a diverting loop ileostomy to protect the connection.
Absolutely. The judgment to choose the right vehicle for the right terrain is what makes a master surgeon. And there is just so much more depth to this material that we couldn't even touch on today.
Oh, definitely.
The book has intricate algorithms from benign colonic diseases, the highly debated timing of medical versus operative management in complicated diverticulitis, and the vast nuances of those perioperative ERAS protocols that ensure a patient actually thrives from day zero all the way to discharge.
It really is a remarkable text that clearly shows how surgery is a discipline of profound intellectual judgment, just as it is a physical craft of the hands. And so we leave it to you, the listener, to reflect on where you think the ultimate balance lies between anatomical foundations and technological advancement.
It's a lot to think about.
It is, but as you do, remember our topographic map. No matter how advanced the vehicle you are driving becomes, the sheer drop of the cliff is still there, waiting. As Dr. Ahmed perfectly states in Colorectal Surgery Code, the best operation begins before the first incision and continues long after the last suture. Thank you for joining us on the debate.